Welcome to The Explainer. Today, we are doing a deep dive into systemic sclerosis. Now, this is a disease that, unlike a lot of its autoimmune cousins, has been incredibly resistant to major therapeutic breakthroughs. We're going to really dig into the fundamental pathophysiology here to understand what makes it such a huge clinical challenge.
This quote really hits home. When you think about other rheumatological conditions, like lupus, for example, well, the progress there has been astounding. 5-year survival rates are up near 90%. But systemic sclerosis, or SSC, it's just a different beast. It remains a massive, unresolved problem, with a prognosis that, frankly, has been historically severe.
All right, so here's how we're going to break this down. First, we'll establish the core pathological triad that makes this disease tick. Then, we'll trace the cascade from that initial vascular injury all the way to fibrosis. After that, we'll get into the two main clinical types, diffuse and limited. And we'll wrap up by looking at the earliest clues, both in the clinic and in the blood work, that help us diagnose and predict what's coming.
So let's get right down to the fundamentals. What is it about the pathophysiology of SSC that makes it so unique? Well, it really boils down to this core triad of processes: vasculopathy, fibrosis, and autoimmunity. And it's the specific combination of these three that creates a disease unlike almost any other autoimmune condition out there.
I really like this slide because these pathological dials give you a fantastic way to visualize the difference between SSC and something more familiar, like lupus. In lupus, that inflammation dial is cranked all the way to the max, but in SSC, that dial is barely on. Instead, the dials for fibrosis and a very specific kind of vascular damage are turned all the way up. This is exactly why we often call SSC an inflammation-poor disease, and that's a distinction that has huge implications for how we even think about treating it.
And this brings us to an absolutely crucial point of distinction. We're not talking about vasculitis here, which is an active inflammation of the vessel wall. In SC, the first thing that happens, the key initiating event, is a non-inflammatory vasculopathy. It's a primary injury to the delicate inner lining of the vessel, the endothelium. This one event is the spark that lights the entire destructive fire.
Okay, so we've established that initial endothelial injury as the big first step. Now we can trace the pathogenic cascade from there. Think of it like a series of dominoes falling, one after another, leading from one damaged tiny blood vessel to the widespread, debilitating fibrosis that really defines this disease. This slide lays out that chain reaction perfectly. It all starts with that vascular insult. That spark leads to tiny blood clots forming, which in turn leads to profound tissue hypoxia. The tissue is literally starved of oxygen. This oxygen deprivation then kicks off a messed up repair response, activating these cells called myofibroblasts, and these are the key players in fibrosis. They get driven by powerful signals like TGF-beta and just start pumping out massive amounts of collagen and other scar material. This is what's known as the endothelial to mesenchymal transition, and it's how a blood vessel problem becomes a full-blown systemic scarring disease.
Now, this underlying process doesn't look the same in every patient. Clinically, it shows up in two main forms, or phenotypes. They're separated by how much skin is involved, but make no mistake, both carry the risk of severe, life-threatening damage to internal organs.
Let's be absolutely 100% clear on this, because it's a huge clinical misconception. The words limited and diffuse only describe the pattern of skin thickening. They tell you nothing, absolutely nothing, about how severe the disease is. Both forms are equally devastating. They just tend to damage different organs and have different mortality patterns.
This table breaks it all down beautifully. With diffuse SSC, fibrosis is really the dominant process. You get widespread skin involvement and, most critically, a high risk for rapidly progressive interstitial lung disease, which is scarring of the lung tissue itself. On the flip side, with limited SSC, the vasculopathy is the main driver. This leads to that severe, long-standing Raynaud's and the often fatal complication of pulmonary arterial hypertension, or PA.
So you've got these two different clinical paths. But interestingly, for almost every single patient, the journey starts in the exact same way, with one highly characteristic symptom.
And that symptom is Raynaud's phenomenon. It's this episodic, reversible vasospasm of the arteries in the fingers and toes, usually triggered by cold or stress. It's famous for this classic three-phase color change, and you can remember it with the mnemonic PCR. First, pallor, or white, from the vasospasm. Then cyanosis, or blue, as the tissue gets deoxygenated. And finally, redness, as blood rushes back in.
It is far and away the most common and earliest sign of SSC.
But here's the clinical problem, right? Not everyone who has Raynaud's has SSC. So when a patient walks in with this, how on earth do you figure out if it's just a benign primary condition or if it's the first alarm bell for very serious underlying autoimmune disease?
Making this distinction is absolutely critical, and the clues are right there in the patient's history and a few key tests. So primary Raynaud's usually shows up in young women and their ANA blood test is negative. In contrast, the secondary Raynaud's that we see with SSC tends to start at an older age, the ANA is positive, and the symptoms are often severe enough to cause painful ulcers on the fingertips. But the real smoking gun is what we see in the tiny blood vessels of the nail folds. We can look at them under a microscope, a test called nail fold capillaroscopy, and see these very specific structural changes, like enlarged capillaries and areas where they've dropped out entirely.
So if you combine those clinical findings with the capillaroscopy and then add in some specific blood markers, you can get even more precise. You can not only diagnose the disease, but even start to predict how it's going to behave down the road.
When you have this high-risk triad, Raynaud's, a positive ANA, and those abnormal nail fold capillaries, we now classify that as very early systemic sclerosis, or VES. Finding patients at this early prefibrotic stage is a huge goal because it might be our only window to intervene before irreversible organ damage sets in. And the stakes couldn't be higher. We know that over 2/3 of patients who meet these criteria will go on to develop full-blown classified systemic sclerosis.
And we can get even more granular. There are these 3 highly specific autoantibodies that act like molecular fingerprints for distinct clinical profiles. So as you can see, anti-centromere antibodies are tightly linked to the limited subtype and its main complication, pulmonary arterial hypertension. On the other hand, anti-topoisomerase, or SCL70, and anti-RNA polymerase III are big red flags for the diffuse subtype. They predict a much higher risk of severe interstitial lung disease and the dreaded scleroderma renal crisis, which is a true medical emergency with a rapid spike in blood pressure and acute kidney failure.
So to pull this all together, the main story, the key takeaway, is this pathogenic narrative right here. It all starts with some unknown trigger that causes widespread injury to endothelial cells. And this primary vasculopathy, in turn, unleashes a relentless, self-perpetuating fibrotic process that ultimately defines the disease and causes all of its devastating damage.
You see, understanding this fundamental pathway from vessel to scar isn't just some academic exercise. It focuses the entire research field on one central question. Can we get in there early, at the level of that initial vascular injury, before the fibrotic cascade just takes off and runs on its own? Can we finally develop therapies that can shut down those myofibroblasts and maybe even reverse the scarring that's already there? The answers to those questions? Well, that's where all future treatments lie. And that's where the hope is for changing the story of this truly devastating disease.